Hey everybody, this is Andrew. So my content map this semester will be on basically things related to our respiratory module, um, namely SARS, rhinoplasty, chest trauma, which also includes flail chest, hemothorax, pneumothorax, and we're going to talk a little bit about chest tubes as well. So to first start off on SARS, let me just share this screen here. So for SARS, we're going to cover some causes, the risk factors, clinical manifestations, and precautions. So the causes for SARS is it's caused by the coronavirus. SARS is an influenza type virus transmitted by particle droplets. Some risk factors is it's mainly geographic, right? So recent travel to mainland China, Taiwan, Hong Kong, and on a related note, prevention. So if you don't want to contract SARS, basically just don't travel to those territories, or just avoid people who have contracted SARS. Some clinical manifestations. So SARS, patients with SARS typically they have flu-like symptoms, such as like chills and shaking, cough, fever, headache, muscle aches, and they have mild respiratory symptoms, followed after a few days by interstitial lung congestion. That's like 2 to 7 days. They also have dyspnea and cough. Some precautions that are taken, airborne precautions, isolations, right? So what are your MTVs, right? So your S of the MTV will be SARS. What that means is mainly the N95 mask, but they can also be placed in a private room, negative pressure, just because it's just so contagious. All right, so on to rhinoplasty. Just a brief description about it, just to gain some context. So it's basically a nose job. It's a plastic surgery procedure that is mainly to reconstruct the form of the nose or restore its function. But basically, it's mostly for aesthetics. Like you can see here, Blake Lively. You can see a before and after pic, and you can definitely tell like something. You know, she's had work done on her nose. Complications. So complications of rhinoplasty can include excessive swallowing. Excessive swallowing is a sign of bleeding and drainage into the oropharynx. So what do we do if that's the case, right? As nurses, nursing intervention. So we assess first, right? Assess when they're not in distress. So we assess the oropharynx first, and then take the vital signs. We assess the patient for frequent swallowing, which may be a sign of bleeding. Bleeding may not always be external after the surgery, because blood may actually run down the back of the patient's throat. Another intervention is patient teaching, right, which is also very important. We want to teach a patient to sleep on at least 2 pillows. What this does is it elevates the head and decreases edema. We also want them to avoid any activities such as bending over or anything that would increase intracranial pressure that may cause or make nasal bleeding worse. We also want to teach them to use a humidifier. What this does is it decreases the dry throat effect when we're doing so much mouth breathing, because we can't breathe through our nose. So lastly, we also want to teach them to sneeze through their mouth. Obviously, we don't want them to use their nose, right? So whenever they sneeze, gotta sneeze through their mouth. We also don't want them to blow through their nose as well. All right, so the next section and topics that we're going to cover in this concept map are flail chest, hemothorax, and pneumothorax. So to start off, in flail chest, the patho, so it's mainly caused by multiple rib fractures, which results in floating section of the ribs. It also causes paradoxal chest movements, which is pretty unique to the inspiration and expiration movements. So when we breathe in at inspiration, the force of the fracture the force of the inspiration actually pulls the fractured segment inward while the rest of the chest expands. When we exhale, the force of the expiration pushes the fractured segment and that balloons outwards while the rest of the chest moves inwards. Some like clinical manifestations for flail chest are the patient will experience tachypnea, shallow rapid breathing, and diminished lung sounds. Treatment management. So first, the goal of the treatment is to prevent atelectasis and related complications. So we will actually want to encourage the patient to cough and deep breathe. But some specific treatment and management, more specific ones are like intubate. So intubation is one, mechanical ventilation. So at mechanical ventilation, there's gonna be positive pressure ventilation. So what that does is it provides support and stabilization for the flail segment. It also improves breathing and gas exchange. Okay, so in hemothorax, so I just want to give a brief description on what it is. So it's an accumulation of blood in the pleural space resulting from injury to the chest, diaphragm, lungs, and blood vessels, and the mediastinum. So this is, it's in contrast to a pneumothorax, right? So pneumothorax is a collection of air in the pleural cavity resulting in the collapse of the lung on the affected side. So in pneumothorax, there's actually three kinds, right? So there's open, closed, and tension. So what open is, it's basically traumatic, right? It's caused by trauma. It's caused by a blunt or penetrating injury that disrupts any parietal or visceral pleura. And it's also iatrogenic, or it could be iatrogenic. It could be caused by medical procedures. For instance, like a thoracentesis, sorry. Anything basically that is, what do you call it? Invasive, right? So closed pneumothorax, it's caused when air or gas gets into the pleural space without any outside wound. And lastly, we have tension pneumothorax. It's caused by a rapid accumulation of air in pleural space that does not escape. There's air trapping. So there's effects on the system. So let me rephrase. So tension pneumothorax has an effect on various systems, right? So, well, first of all, there's already extremely high intrapleural pressures resulting in tension on the heart. So what that does is it causes hemodynamic instability. So what that is when the heart is being pressed, right, the cardiac output is going to go down. The heart's going to try and compensate by increasing. But at the same time, the blood pressure is going down, and there's also increased respiration rate. So a big sign and symptom of tension pneumothorax is actually a tracheal shift away from the affected side. So what's that called is that it's a tracheal deviation. So here, in this diagram, you see that, so here is where the tension pneumothorax is. So it's actually, due to the buildup of pressure, it's actually pushing the trachea to the unaffected side. So sign and symptoms is that, so the tracheal shift away from the unaffected side, and hyperresonance on percussion, and JVD. So I just want to correct myself. So this says tracheal shift away from the affected side, which is true. I may have said tracheal shift towards the unaffected side, or that's what I meant, a tracheal shift towards the unaffected side, and a tracheal shift away from the affected side, right? So That's what this diagram is showing.
So on the next topic of chest tubes, I think it's a good idea just to start off with a brief description of the different chambers that are in the chest tube system. So here's already a picture of it, but see if I could share another one with you. Yeah, so here is a chest tube system that is set below the patient, which is sitting on the bed. That's a very important point because the system will not properly drain if it's not set below the patient's chest. So as far as for the first collection chamber, for the first chamber, it's called the collection chamber. So the collection chamber collects fluid draining from the patient. So what is useful about this is not only is it collection, but you can measure the volume that we've collected from the patient, but also nurses, when they will actually mark off the time for when they've measured. So we could actually even measure like a rate for how much the patient is draining. Like for instance, whatever cc's, even per hour, we can figure that out just by marking it off at how much and at what time. So for the second chamber here it's called the water seal chamber. So that's the second one. So the water seal chamber allows air and fluid to leave the pleural space, but prevents reentry back into the chest. So it acts as like a one-way valve, right? So whatever we're draining from the patient, we want to make sure that it's leaving and staying outside and in this drainage system, and it doesn't go back into the patient. So that's what the water seal chamber really does, right? The third chamber is called the suction control chamber. It provides a suction control of the chest tube system. There's actually two forms of the suction control. One is wet and one is dry. So the wet system, well, this one's actually, let's start off with the dry system because that's what this appears to be. So the dry suction, you can see there's no water added to the chamber. With no water, there's also no bubbling, right? So what's in it? It looks like kind of like an orange floater ball that'll appear in this chamber that indicates like the proper suctioning. So its counterpart is the wet suction control. That's more of a traditional chest drainage unit. So that will be filled with water in the chamber that controls the suction to the lungs. And typically there's about 20 centimeters of water. So since there's water in there, there will be bubbling, and that bubbling will be continuous in the suction chamber.
So next we'll talk about chest tube indications. So the first indication is titling and fluctuation. So that usually happens, so that's bubbling, right, in the water seal chamber. Some general characteristics of this is that it indicates that air is draining from the patient. It occurs when intrathoracic pressure is higher than atmospheric pressure. It also may occur during exhalation, coughing, and sneezing in the patient. Some characteristics of bubbling during inspiration and expiration. So there's intermittent bubbling, which is normal. So what intermittent means, like it's not constant. So this indicates that the chest tube is accomplishing one of its purposes, or actually its main purpose, right? So in removing air from the pleural space of the patient, and also reflects change in pressure. In contrast, when there's continuous bubbling, this is definitely abnormal. This indicates that there's an air leak that exists, and since there's an air leak, this must be corrected immediately. Us as nurses, we have to perform a focused respiratory assessment. So in this assessment in the patient, we have to check for respiratory difficulty and check for subcutaneous emphysema. So the third indication is also excessive bubbling. Excessive meaning vigorous. So this is also abnormal and unexpected, and it may also indicate an air leak. Okay, so you see the unit is below the patient, very important. Next, I think the RN is going to mark off the volume and time. So he's gonna mark off where, so what time, how much drainage there is. Oh, and here you go. This is the, so basically this is the bubbling in the water seal chamber. So what is normal is what you see here, the intermittent bubbling, right? See that? So it's not constant, right? So intermittent is normal. It's signifying that the unit is performing its job. If it's not, so if it bubbles like this, but if it's constant, that means there's something wrong. That's abnormal. So next we're going to talk about chest tube complications. So this includes air leakage and chest tube dislodgement. So air leakage is, we've kind of covered this earlier, but again, air leaking into the tissue surrounding the chest tube, and that can result in subcutaneous emphysema. So some signs and symptoms of subcutaneous emphysema on assessment of the patient is a crackling sensation that will be felt when we palpate the patient. Some complications that can happen are severe subcutaneous emphysema, in which it can cause a drastic swelling of the head and neck, and potentially the airway will be compromised. So one big complication is tension pneumothorax, and that's because there's just a large and persistent air leak with no evacuation outlet. So basically air is getting in, there's no way for it to get out. So some classic signs and symptoms, or the classic sign and symptom of a tension pneumothorax on assessment, is a tracheal deviation. And I know we went through another diagram, but here's another one, an X-ray. So you can see the trachea, it's actually severely being shifted towards the unaffected side by the tension pneumothorax that is existing here. So basically air is getting in, can't get out. So it's pushing the trachea towards the unaffected side. And with that too, it's gonna also compress the heart, right? So the heart's gonna be compressed. And as I said earlier, when that happens, cardiac output goes down, perfusion goes down, heart rate goes up, respiration goes up, blood pressure goes down, other organs started getting affected, and it's just bad. It's bad news, this tracheal deviation. So this happens, it's an emergency event, so we have to prepare them for emergency needle decompression. So that's a treatment. Again, tracheal deviation, asymmetric chest wall expansion. So when there is an air leak, we want to try to find that, right? So there's some steps to do that. So we want to pinch the chest tube closest to the patient's chest. So if the bubbling stops, the leak is in the patient or the pleural space. If the bubbling continues, we know that the leak is below the pinched area. So we have to check the system for the reason for the kink, or not the kink, the air leakage, sorry. So the other chest tube complication is actually when the chest tube gets dislodged. So there's a prior intervention here. So we want to first cover the insertion site if the chest tube does get dislodged. We want to cover that with a sterile gauze and apply occlusive dressing. So second, we want to tape that dressing with a three-sided the tape method or technique. And third, we want to contact the HCP. So this concludes my concept map. I hope this was informative for you guys. Just a quick rundown again, we went through SARS. So main idea in SARS is that what are the precautions, right? So it's airborne precautions, isolation, specifically the N95 mask. In rhinoplasty, nursing interventions, what do we assess first? We assess their oral pharynx first, then take vital signs. And that's because we're assessing the patient for frequent swallowing, and that could be a sign of bleeding. So for Flail Chest, the treatment is intubation and mechanical ventilation, and more specifically, positive pressure ventilation. In hemothorax versus pneumothorax, hemothorax is an accumulation of blood, pneumothorax is an accumulation of air. With that, there's 3 types of pneumothorax. There's open, close, and tension. In tension, the classic sign and symptom is a tracheal shift away from the affected side, or you could say a tracheal shift to the unaffected side. In chest tubes, there's 3 types, or there's 3 chambers. There's the collection chamber, which is the first one. The second one is the water seal chamber. Third one being the suction control chamber. Characteristics of bubbling during inspiration and expiration in the water seal chamber. So if that's intermittent, not constant, that's normal. If the bubbling is continuous, that's abnormal. That may indicate an air leak. And so in air leakage, so we want to monitor for complications, right? We want to monitor for a possibility of air leakage. So the air leakage into the tissue around the area surrounding the chest tube can result in subcutaneous emphysema. So large and persistent air leak into no evacuation outlet can result in tension pneumothorax. So again, air is going in, but it can't get out, it can't escape. So a classic sign and symptom, again, it's tracheal deviation, which I just mentioned. And another one is chest tube dislodgement is another complication. And with that, there's 3 steps in priority intervention. It's first to cover the site, second is to tape using the 3-sided tape technique, and third, we contact the provider. All right, guys, I hope you enjoyed it, and good luck in your studies.